Welcome back to Government School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. This is a series of lectures on electrocardiography as an add-on course for undergraduates, residents, and those who are interested in understanding ECG. This will be partly online and partly offline. The learning objectives are to understand the cardiac electrophysiology, describe the conducting system, and interpret the basic ECG pattern. That is our target. We know that ECG is a graphic recording of the electrical activity of the heart. For example, in a pond, you are throwing a stone. This will produce waves in various directions. And think that the heart is situated, or the chest is the pond, and you are recording the electrical activities from different angles using surface electrodes. And these surface electrodes are called the lead system or leads. So we are looking at the heart from different angles to understand the electrical activity of the heart. So this is basically it is the electrical activity that is recorded. Now we go into the history of the ECG. The PQRST nomenclature was given to the ECG, and it was in 1887 Augustus Waller who recorded the first human ECG. So here you can see the recording that he has done. This was in 1887. It was William Einthoven who developed the string galvanometer. So the principle of electrocardiography is very simple. So it is a modified galvanometer. The machine is called electrocardiograph. It is a modified galvanometer. So we know in a galvanometer, when the current comes towards the positive pole, it will produce a positive deflection. If the current goes away, this will produce a negative deflection. And if the current is coming vertically, this will produce a equivocal deflection. That is what is happening in ECG. In the electrocardiographic paper or electrocardiogram, the deflection going upwards is positive, deflection going downwards is negative. This is in contradiction to what is mentioned in neurophysiology or neuroelectrophysiology. So this is the Einthoven. So the machine is electrocardiograph. It is a modified galvanometer. The recording is electrocardiogram. As mentioned, during depolarization, we know that the cell, the inner part of the cell is negative, and during depolarization it is changed due to the sodium pump. So the depolarization wave comes, there's a rapid influx of sodium. This is the sodium producing a rapid deflection, followed by the repolarization wave due to the potassium efflux. And these changes are recorded by surface recordings. And so we can say that we are looking into the heart from different places, like the blind men of Hindustan. And that is why the ECG in different leads looks different. For understanding the electrocardiogram, we should know the conducting system. So heart has got a pacemaker. That pacemaker is the SNOD, is the natural pacemaker. So SNOD is situated in the atrium near the superior vena cava. The impulse is generated through specialized conducting system. It depolarizes the atria. It reaches the AV node where there is a delay, and from there the bundle of is it divides into the right bundle, the left bundle divides into an anterior division and a posterior division. This arborizes into the Purkinje system from endocardium to epicardium. The depolarization wave is traveling and the ventricles are depolarized. So this is what is happening. There is a delay in the AV node. If there is no delay, what will happen? The atria will contract and there is no time for the ventricles to relax and accommodate the blood that is coming from the atria, and so the filling will be defective. That is why there is a delay in the AV node. This is an important point to remember. So this is the conducting system. Here you can see the SA node, the specialized system which depolarizes the atrium, right atrium and left atrium, reaches the AV node. There is a delay. The bundle of is divides into the right bundle, left into anterior division, posterior division, from endocardium to epicardium. All of you should be able to draw this picture. So as mentioned, what happens if the AV node does not have any delay? We already mentioned that this will produce poor filling of the ventricles. Hope it is clear to you. This is the wave. This is due to the sodium entry, and this is the potassium repolarization. For further details, you look into the physiology. So remember, depolarization is due to sodium influx, repolarization is due to potassium efflux. And this electrical activity leads on to contraction. That is, electrical activity precedes the mechanical activity. Now we go into the electrocardiogram. So what is the P wave? So this is the P wave. The P wave is due to the atrial depolarization. Remember, it is not atrial contraction, it is the atrial depolarization. This is the AV valve, this is the atria. So atrial depolarization produces the P wave. So once the atrium is depolarized, there is a delay in the AV node. So there is a silence, and this silence is in the electrocardiogram is the PR segment. Don't confuse with the PR interval. Interval always contains a wave. This is a line segment, so it is electrically silent. Then comes the depolarization of the ventricles. Septum is depolarized, then the ventricles are depolarized. This leads to a huge electrical activity that is recorded as the QRS complex. Even if there is no Q wave, this nomenclature is this QRS complex. Then again, after depolarization, there is a silence, electrically silent, that is the ST segment. Just like the PR segment, ST segment is also isoelectric. There is no electrical activity. And the beginning of the ST segment is called the J point. So remember this, the J point. Once the depolarization is over, the ventricle relaxes, or not relaxes, it produces repolarization. This repolarization is the P wave. So P wave is to atrial depolarization, there is a delay, the QRS complex with the ventricular depolarization, ST segment, there is no electrical activity, then the T wave due to ventricular repolarization. The repolarization of the conducting system can sometimes produce a wave called the Q wave. So this is the nomenclature, the anatomy of the electrocardiogram. So this is a bigger picture. Two intervals you should know, two segments you should know. So intervals are, one is PR interval. So this is the PR interval. PR interval includes a wave. This is the beginning of the P to the beginning of the QRS. So this is the PR interval. So as mentioned, PR interval. So this is the PR interval. This contains a wave. Then comes the QT interval. QT interval is from the beginning of the Q wave to the end of the T wave. So this is the QT interval. So PR interval plus QT interval completes the electrocardiogram. Two segments you should know. One is the PR segment, which you already mentioned. This is the PR segment, and this is the ST segment. It is very important because changes of myocardial infarction, ischemia, etc. We are looking at the ST segment. So all of you take a piece of paper, draw this ECG and learn it. Then we will go to the ECG machine. The machine is a modified galvanometer. I already mentioned this is a modified galvanometer. So when the current goes towards the positive pole, this is a positive recording, this is the recording electrode, and this is the negative. If the current goes to the positive pole, this will produce a positive deflection. Anything upward is positive. When the current is going away from the positive, this will produce a negative deflection. If the current, so this is the concept you should remember. So the paper is running at a speed of 25 small divisions per second. Remember, it is 25 small divisions. And the calibration is when the machine is given 1 millivolt, this will produce a deflection of 10 millimeters. So in the ECG, usually routinely you see the standardization like this. Sometimes it is put as half standard when the voltage is very high, you make it as half standard. Sometimes the paper is run at a speed of 50 per division, then it will be written separately. If it is not written, remember the paper is running at a speed of 25 divisions per second, small divisions per second, and 10 millimeter is equal to 1 millivolt. So this is the machine. There are different models are there, you are familiar with it. So the calibration, you should remember, 25 small division is equal to 1 second. So this is every fifth line is volt. So the paper is running at a speed of 25. So x-axis is time and y is voltage. 25 small division is 1 second. So 1 division is equal to 1 by 25 is equal to 0.04 seconds. So this is 0.04 seconds. 5 division will be 0.2 seconds, that is 0.04 into 5. So this is the minimum thing to remember. I will repeat once more. 1 small division is the paper is running at a speed of 25 small divisions per second. So 1 small division is 0.04 seconds. And a large division, that is 5 small division, is equal to 0.2 seconds. This you should remember. This is a enlarged view. The same thing is repeated. You can see this is the 1 large division is equal to 0.5 millivolt. And 1 small division is 0.04 seconds, and 1 large division is 0.2 seconds. Okay. So we have mentioned the components of the ECG tracing already. The P wave is P2, atrial depolarization. We have mentioned about the PR interval, the QRS complex, ST segment, T wave, and QT interval. Be familiar with it. And this part is called the J point. Now we will be looking into the lead placement. Leads are the surface electrodes. For the recordings, the electrodes which are used for is called the leads. Basically, a normal ECG has got 12 leads. That is why this ECG is called 12 lead electrocardiogram. 3 are from limbs. They are called 3 limb leads, named as 1, 2, and 3. There are 6 chest leads. They are placed on the chest, that is called chest leads. There are unipolar leads called Wilson's leads, which are augmented. Once it is kept on the right side, it is called AVR. It is on the left side, it is called AVL. On the foot, it is called AVF. So in total, usually there are 12 leads, and that is why the standard ECG is called 12 lead electrocardiogram. If you want, you can have special leads. So then it will be written separately. You can keep the leads in the esophagus. This example is in a special lead. This esophageal leads. So then we take the limb leads. The limb leads are recording from the frontal plane. So the potential difference between the right arm and the left arm is called lead 1. So when you are connecting the right upper limb with left upper limb, either in the shoulder, but routinely we are keeping it on the arms. That is lead 1, where the positive is on the left side. So this is the potential difference we are looking. From the left side, we are looking into the heart. That is the concept. So lead 1 you represent like this. This is positive, this is right, this is left. Lead 2 is the potential difference between the right arm and the left foot. So it is represented like this. Positive is on the here. Lead 3 is the potential difference between the left arm and left foot. You draw like this. Again, positive is here. So that is what is shown here. Lead 1, lead 2 and this is lead 1, lead 2, lead 3. Hope it is clear to you. And this triangle that you have produced is called the Eindhoven's triangle. Then comes the augmented leads or Wilson's leads. So there is no negative, there is an exploring electrode or recording electrode, other is made neutral and is augmented. So it is once it is kept on the foot, it is called AVF. Recording electrode is on the left side, it is called AVL. On the right side, it is AVR. So we have got AVF, AVL and AVR. Hope it is clear there. So remember, these are leads that are looking into the heart from the front. They are looking in the frontal plane. Now we go into the chest leads. Chest leads are named V3 to V6 normally. V1 is on the right side on the fourth space. V2 is on the fourth space on the left side. V3 will be between V2 and V4. V4 is in the fifth space in the midclavicular line. V5 is on the anterior axial line again in the fifth space, and V6 is in the mid-axial line fifth space. So V1 is on the fourth space on the right side, V2 same fourth space on the left side. This is in the fifth space in the midclavicular line. This is in the axial line. Sorry, V3 is between V2 and V4. V4 is in the midclavicular line. V5 is in the anterior axial line and V6 is in the mid-axillary line. We can keep special leads. For example, the V3 can be placed on the right side. Then it is called V3R. There is no V2R because V2 is fixed. V1 and V2 are fixed. Then V4 can be kept on the right side. It is called V4R. Same way you can go behind. So in the standard electrocardiogram, we have only 12 leads. Sometimes, especially in right side myocardial right ventricular infarction, you ask for a V3R and V4R. So we have to identify the ECG paper marking and practice the lead placement and common errors. So remember, what is the normal ECG paper speed? 25 small divisions per second. What is a natural pacemaker? It is the SA node. QRS complex represents ventricular depolarization. So take home essay, ECG records electrical activity of the heart. SA node is the natural pacemaker. You should always check the calibration. Systematic interpretation is essential. ECG is indispensable. The following modules will be diving more into this. Stay tuned. Thank you.